So thank you all for giving such a warm welcome to the Representative Bush Paris, Senator Blake Tillery, and Representative Matt Hatchett. Thank you so much for this first ever opportunity for us to have this discussion with the esteemed panelists. So we truly appreciate you. Continuing on with our program, and thank you all again for his moderation. But continuing on with our program, we're now beginning our resident research presentation and competition. This session allows for the residents to showcase their current research. It's also a wonderful networking opportunity for all of you here this weekend who are interested or in similar topics. Dr. Teresa Bird is the chairman of the Education Committee and will be the moderator for the poster competition today. We will also have a brief question and answer session after each lecture. Just to introduce Dr. Bird, she is an academic leader in obstetrics and gynecology and currently serving as the director of the OBGYN residency program at Wellstar, Kennestone, and Marietta. She is a native of Los Angeles and earned her medical degree from Mary Harry Medical College and completing her residency at the University of Texas at Houston. Dr. Bird has dedicated her career to medical education, quality improvement, and advancing diversity and equity in healthcare. She is actively involved in initiatives to reduce Black maternal mortality and serves on several national and state national committees, including GLAP-QC and also the District for Health Equity and Reflective Care Committee. So welcome to the stage, Dr. Teresa Bird.
Good morning. I'm excited now to introduce the residents here. I just want to take a second to highlight all the program directors and associate program directors in the room. So if you don't know, there are 6 OBGYN residency programs in the state of Georgia. If I could have all the program directors and associate program directors stand so you guys can see who's responsible for the training of residents in your state. And I'm happy to be in your cohort. So with that, we are going to start with the resident presentations. First, I will introduce my resident, Dr. Annie Zhu, who is from Wellstar, Kennestone. She is going to present on CATAPULT home blood pressure monitoring in pregnancy. Dr. Zhu.
Hi. Good morning. Thank you for being here. My name is Annie Zhu. I'm a 4th-year resident at Wellstar, Kennestone. My presentation today is going to be on home blood pressure monitoring in pregnancy. My mentors were Dr. Marcia Little and Dr. Teresa Bird. Okay. So I have no disclosures. So the idea for this project stemmed from CDC data on maternal mortality. So in 2020, the maternal mortality rate went from 23.8 to 32.9 deaths per 100,000 live births. Now in Georgia, the maternal mortality rate reached a high of 42.9 deaths per 100,000 live births in 2021. The highest concerns for causes of maternal mortality include inadequate follow-up of cardiovascular symptoms in pregnant women and failure to recognize and treat hypertensive disorders in a timely fashion. So hypertensive disorders of pregnancy encompass a whole range of diagnoses, from chronic hypertension, gestational hypertension, preeclampsia with and without severe features, and chronic hypertension superimposed preeclampsia with and without severe features. There's been a multitude of prior studies that have highlighted the efficacy and the feasibility of home blood pressure monitoring in pregnancy. And of course, most of these studies have mixed conclusions on whether home blood pressure monitoring in pregnancy can actually reduce antenatal hospital visits without compromising care. With that being said, a lot of these studies also show that there is a potential for home blood pressure monitoring, and it can be a viable adjunct to routine prenatal care, and we try to see if we can recreate this study in our own patient population. Sorry, one more. So the hypothesis for my study is that in patients with a known hypertensive disorder of pregnancy, antepartum and or postpartum home blood pressure monitoring with education will lead to earlier recognition of warning signs and also leading to fewer interventions, leading to quicker interventions and fewer unscheduled hospital visits and readmission rates. The primary outcomes we looked at were patient participation with home blood pressure monitoring and reporting, and some of the secondary outcomes we looked at were medical interventions, hospital visits, and readmission rates related to home hypertensive disorders of pregnancy. So this was a quality improvement project in collaboration with the Georgia Department of Health, and we did receive a CDC grant and IRB exemption. So the materials and methods part of the study. So we initially enrolled 21 patients who already had a known hypertensive disorder of pregnancy, and we provided each and every one of them with a home blood pressure cuff and also a blood pressure machine. We educated them on how to accurately measure their blood pressures at home. We also provided patients with a blood pressure log, and our instructions were to monitor your blood pressure twice daily until 6 months postpartum. We gave education on warning signs and symptoms and created a diagram showing patients when they would need to present to the hospital. And we also had provider resources that were made. We had a medication algorithm that was made where if patients were already on an antihypertensive, we had a unified way of titrating their blood pressure medications. We also had made a flow sheet based on different scenarios and what the patients might present with and the next steps and when to present to the hospital. We started a MyChart message, which is a patient messaging platform, and asked the patients to upload their blood pressure logs once a week for review. And we looked at monitor medication adjustments, hospital triage visits, as well as other specialty referrals, including family medicine, internal medicine, and cardiology. As you can see on the slide, this is just an example of a blood pressure log that a patient has sent. Our project lasted from March to September of 2023. So the top right-hand side, this is a brochure that was taken from the preeclampsiafoundation.org. It just highlights basic facts and symptoms for patient use. On the bottom is the patient handout that was sent with highlighting the red flag symptoms and when the patient should present to the hospital. Now on the left side are the provider resources. The top is the medication adjustment protocol for patients who are already started on an antihypertensive. And the bottom is a flow sheet diagram with just different scenarios and what the patient could present with and how to go about with the next steps. And as you can see, most of the next steps do point to hospital visit with lab draws. So our patient demographics, most of our patients were Black and were diagnosed with chronic hypertension. Now, these diagnoses were all what patients presented with at initial recruitment into the study. We looked at patient participation rates, and we noticed that the participation rate was the highest at 71% in the first month of recruitment and the lowest in the postpartum period. In terms of hypertensive disorders of pregnancy and readmission rates, and when patients had measured their blood pressures at home, we did have 2 hospital readmission rates. Both of these were for preeclampsia with severe features in the postpartum period. We had 4 hospital evaluations, 3 medication adjustments, and these 3 were all from patients with chronic hypertension. We had 12 other specialty referrals and 5 patients that were lost to follow-up. So this study was meant to be a pilot study that was helping to, for us to create a successful home blood pressure monitoring program and also lead us to look at next steps and what the future projects could entail. We had a significant decrease in participation rate in the postpartum period. And what we noticed was that some of the challenges we had were we did have a small sample size. We had initially a delay in receiving blood pressure cuffs and machines to give to our patients, and our project was limited to a duration of 7 months. We had limited availability in clinic to see patients when they were referred to the hospital, and there was initially a delay in blood pressure review as the logs were being sent to a clinic pool instead of directly to the primary investigator. But overall, home blood pressure monitoring can be a viable adjunct, and we did have 2 patients who did present to the hospital for readmission for postpartum preeclampsia with severe features. They did get quicker intervention, and they were readmitted and had received care in a more timely fashion. So some further studies that we're looking at, the next steps would be to implement this study in a larger sample size. We're also looking towards giving our patients a Bluetooth monitor device, a blood pressure device with an app that's connected so that once the patient is able to take their blood pressures, it is automatically logged into the app. The app will remind the patients of when to go to the hospital. So this will most likely help increase blood pressure compliance and reporting, hopefully. We also are looking at integrating telehealth visits within our practice and also possibly including all language-speaking patients in our practice as well. Thank you.
Any questions for Dr. Zhu?
Thank you, Dr. Zhu, for your presentation. I have a question about the 2 patients that were readmitted with postpartum preeclampsia with severe features. Did those patients have antenatally or during labor any signs of blood pressure issues? Were they chronic hypertensive? Did they have gestational hypertension, et cetera?
Yeah, so these patients were both chronic hypertensives, and they were on blood pressure medications, but presented for increase in blood pressure 160 over 110 and with some red flag symptoms, and that led them to present to the hospital for readmission.
Okay, thank you, Dr. Zhu. Next, we have Dr. Alexandra Caldwell from Morehouse, comparing the use of perineal massage and warm compress to hands-off technique in the 2nd stage of labor to improve perineal outcomes. Dr. Caldwell.
Good morning, everyone. It's a pleasure to stand before you all today to share with you all my research and my findings. So I'm going to be presenting on, the title here is a little bit different than what is on the program, perineal outcomes after vaginal delivery with application of warm compress, perineal massage, and hands-on technique. I have no actual or potential conflict of interest in relation to this presentation. So just a little bit about lacerations. So if you've been in 1 or more vaginal deliveries, odds are you have seen a laceration or have partaken in the management of a laceration. There are many different types. I won't go down the list today, but they do occur in 30 to 80% of women. There's an incidence of 60 to 70% of those lacerations requiring repair or suture. 60% of women in the first 3 months following vaginal delivery experience dyspareunia. 6 months following vaginal delivery, 30% of women continue to experience dyspareunia, and then up to 3 years following vaginal delivery, 15% of women tend to experience dyspareunia secondary to lacerations. Other acute and chronic complications that can result from lacerations that are typically more associated with our 3rd and 4th degree lacerations, or also known as OASIS, can range from postpartum hemorrhage, postpartum pain, depression, urinary fecal incontinence, fistulas, POP, pelvic floor dysfunction, sexual dysfunction, an increased need for pelvic floor surgery within the first 12 months of vaginal delivery, and also an increased need for surgery for the management of POP and urinary incontinence later in life. And Practice Bulletin 198 actually discussed some of the risk factors associated with OASIS. They typically range from increased fetal weight, nulliparity, forceps or vacuum-assisted delivery, increased or prolonged position of OP, as well as epidural anesthesia, labor induction, and labor augmentation. Some of the risk factors that were not actually associated with an increase in lacerations were maternal age, BMI, increased duration of second stage, as well as pregnancy duration. And so what does the data that we have now tell us? First, I want to start off by defining what is hands-on technique. So essentially, it's when one hand is applying pressure on the fetal head to control fetal head expulsion, while the other hand is simultaneously applying pressure to the perineum. So if you've ever been in delivery, I'm sure you've been told by your senior or your attending, make sure you protect the perineum, protect the urethra. So that's essentially what hands-on technique is. It's something that we typically do, we standardly do at Morehouse. And so what there actually is evidence that shows there is no difference in perineal trauma outcomes with hands-on versus hands-off technique. But ultimately, I have a few excerpts from different papers that ultimately show that there is some benefit. There's some evidence that supports the use of perineal and/or perineal massage and/or warm compress in the reduction of 3rd and 4th degree lacerations. However, the evidence is lacking in terms of the impact on 1st and 2nd degree lacerations. And the last bullet point just highlights one of the things that I mentioned, comorbidity that can be associated with perineal trauma in terms of women who only had vaginal deliveries, including spontaneous, vacuum-assisted, or forceps, versus women who only had cesarean deliveries. There was an increased need for surgery for pelvic organ prolapse and stress urinary incontinence later in life. So the aim of this study was just to offer further insight into the benefits of this intervention with the hopes of ultimately reducing maternal morbidity and long-term complications that can result from perineal trauma. And the hypothesis was that routine application of warm compress and perineal massage with hands-on technique during the 2nd stage of labor would yield a reduction in overall perineal trauma. So this study took place between March 1st of this year and June the 30th. From March 1st until April the 30th, there was no intervention. We just did standard care, so plus or minus hands-on technique. From May the 1st until June the 30th, we implemented our intervention, which was warm compress, perineal massage, and hands-on technique. Inclusion criteria were nullips and multips who had a singleton gestation delivering at Grady, and the primary outcome was perineal lacerations 1st through the 4th degree. So our technique, we basically implemented this intervention at no set time during the 2nd stage of labor. We used 1 and/or 2-hand perineal massage, as well as warm, damp washcloths, and then we also, of course, continued with the hands-on technique. And so these two data tables just pretty much highlight the characteristics. The median age for both the control group and the intervention group were 27. The median gestational age by days was 275, 274 respectively, which equates to 39 and 2 and 39 and 1. And then the median fetal weights were also very similar, 3090 grams for the control group and 3151 grams for the intervention group. I do, however, want to point out under delivery type, you'll see just spontaneous vaginal delivery and vacuum-assisted vaginal delivery. We did not have any forceps deliveries for the months of March through June. And so we ran a univariate analysis, and what it showed us was that there was a statistical significance for 4 of the factors in relation to lacerations, and those were age, fetal weight, intervention, and parity. And so women who were less than or equal to 27 years of age actually had a 22% increase in having a perineal laceration with a p-value of 0.006. Women who had babies who weighed 3208 to 3402 grams or were greater than 3403 grams had a 26% and 32% increase, respectively, of experiencing laceration, with a p-value of 0.02 and 0.01, respectively. For our intervention, women who did not have the intervention, the perineal massage and warm compress, these women had a 42% increase likelihood of experiencing a perineal laceration with a p-value of 0.0001. And then lastly, our no-lips had a 70% increase of experiencing perineal laceration with a p-value of 0.0001. We then ran a multivariate analysis and we controlled for those 4 factors. And after the multivariate analysis, the only factor that had a statistical significance associated with perineal lacerations was parity, with a 36% increase in likelihood and a p-value of 0.0001. Those who did not have the intervention, for those who did not have the intervention, there was a 20% increased likelihood of experiencing a laceration, but it was not statistically significant. So even though it was not statistically significant, there is still some clinical significance, which ultimately means that we as providers should be implementing these interventions in order to help our mothers have a decreased likelihood of the acute and chronic complications that I mentioned beforehand. And so some limitations with this study, we had a sample size of 341. So moving forward, that is something that we could improve by doing a longer study with a larger sample size. Some potential confounding factors that we didn't control for were BMI, the length of second stage of labor, the time at which the intervention was implemented, provider experience, temperature of the warm compress, variation of perineal massage technique, and also epidural anesthesia. My plan is to actually implement a randomized controlled trial starting in October, going through September of next year. And so with that study, I plan to standardize perineal massage training. We want to also try to maintain the warm compress at a set temperature range, potentially using a warmer like the warmers we use in the OR, and keeping the warm compress sterile. And then also focus on the likelihood of lacerations by type, since we know that the severe perineal trauma, the OASIS tears, are more associated with those long-term chronic issues. It would be good to know what are the likelihood of the lacerations by type, rather than the primary outcome just being 1st through 4th degree lacerations. And then lastly, of course, in the upcoming randomized control trial, we want to control for those possible confounding factors that I previously mentioned. These are my references. And I just wanted to thank the Georgia OBGyn Society for this wonderful conference this weekend and allowing me to stand before you to present my research. I wanted to thank my research mentors, Dr. Roland Matthews, who's the chair of my department, Dr. Quita Phillips, my program director, Dr. Remo Alonrewaju, my APD, Dr. Amisa Say, sitting in the audience, who helped with this data collection analysis, and then lastly, Ms. Adenike McDonald, who was my statistician. Thank you.
So, do we have any questions for Dr. Caldwell?
What did you do about patient choice? If a patient came to you in the beginning of the study and said, I want this, did you eliminate them, or did you just leave them in the time?
Yeah, so all of our patients, we didn't have any patients who didn't want to not partake. Fortunately, but I can see that potentially being an issue with a longer study with a larger population size in the upcoming year, for sure. Thank you for your question.
Thank you, Dr. Caldwell. Okay, I see most eyes up, so I will move on to the next presenter. We have Dr. Tanner Fincher from HCA. She will be talking about assessing pre- and post-McDonald cerclage cervical length ratios and cervical suture material types for the prediction of pregnancy prolongation in patients with cervical insufficiency. Tongue tie. Dr. Fincher.
Thank you for going ahead and saying the title of my project so that I don't have to. My faculty mentor for this project is Dr. Royak. I have no disclosures. I would like to bring up the importance of this project and looking at Cerclage outcomes. We've talked a lot about maternal mortality at this conference, but we have the privilege of taking care of 2 patients in what we do, and infant mortality in Georgia is not great either, and the leading cause of that is preterm birth. So this is one of the interventions we can do to help that. So for my project, I looked at 2 different aspects of cerclages. There you'll see a really simple schematic of cervical length and the measurements we perform to assess outcomes related to the findings on the post-cerclage ultrasound. So we looked at the area above the cerclage on ultrasound as well as below, and the total cervical length. The second aspect of the project was looking at the 2 different suture types that we use at our hospital. The top there is the Mercelin tape suture, and then the bottom is the green braided Mercelin suture. This was a retrospective cohort study. We started with about 494 cerclages performed at our institution in a 5-year period. We excluded 254 based on that exclusion criteria that you see there. After that, we had a study population of 240, and when we reanalyzed the data, one of the important things was excluding medically indicated preterm deliveries as defined by ACOG Committee Opinion 831. So we did that, and then we ended up with a sample size of 206 cerclages. This project included prophylactic as well as rescue cerclages. Prophylactic, same as history indicated cerclage, and then rescue cerclage, the exam indicated cerclage. So about 41% were prophylactic and 58% were rescue. So the basic descriptives of all of the cerclages included the gestational age at placement. The mean for that was 17 weeks and 6 days. The length of time the cerclage remained in, 15 weeks and 2 days, and the gestational age at time of delivery, 33 weeks and 1 day. So here, we already went through the schematic. Now we're going to go through some ultrasound pictures to review post-cerclage ultrasounds. So here is a patient with a cervical length of 3.27 centimeters at 11 weeks. This same patient at 20 weeks and 1 day, you can see there's essentially no measurable cervix there and significant funneling. This is the same patient after a rescue cerclage. Circled there is the cerclage suture, and then you see there is a measurable cervix, about 3.12 centimeters. So for this aspect of the project, on literature review, I found some studies. This one was published in the Gray Journal that looked at total cervical lengths and delivery within 2 weeks, delivery before 34 weeks, and they had pretty remarkable relative risks. So our data, for the initial post-cerclage length and correlating that with the gestational age at time of delivery, we performed a Pearson correlation. And just a reminder for biostatistics, for a correlation, anything close to 1 is associated with a strong relationship. So anything above 0.5 is technically strong. So here, that length A above the cerclage was statistically significant and a 0.510 Pearson correlation. And then B was a strong correlation as well. So one of my favorite parts of this was the linear regression that we performed, which there's some very straightforward conclusions we can make. For every millimeter increase in A above the cerclage, this model predicts about 2 days extra of pregnancy. And then for every millimeter increase in B, it's about 4 days extra pregnancy. Now we'll move on to our 2 suture types. There was a study that was published in the Green Journal that compared monofilament braided and Mercelin tape sutures. They essentially found no difference in the groups prior to 23-week deliveries and prior to 37-week deliveries, but there was some difference in the increased risk of delivery prior to 28 or 32 weeks in the monofilament and braided groups compared to Mercelin tape. So, of course, we have to compare our starting characteristics. So for the green braided group, the mean estimated gestational age at time of placement was 18 weeks and 1 day, and for Mercelin tape, 17 weeks and 3 days, but this was not statistically significant. We also looked at the difference in the pre-cerclage cervical length. Mean for green braided was 17.99, Mercelin tape 24 millimeters. And this was statistically significant between the two groups, which is important to keep in mind. So now kind of tying it all together, we looked at the different suture types and how that correlates with those values we were talking about for A and B. Mercelin tape was longer than A, or longer on that variable, and it was statistically significant, and the B value was longer for Mercelin tape as well, and it was statistically significant. Now, for the most clinically relevant part of this talk is what was the estimated gestational age at time of delivery in the two groups. Green braided, 31 weeks and 6 days. Mercelin tape, 34 weeks and 4 days. And that was statistically significant. So that's a lot of results. So to just sum it all up, there is a strong relationship between the length above the cerclage. For every 1 millimeter increase in length above the cerclage, this model predicts about 2 days extra pregnancy. Same goes for B, which predicts about 4 extra days of pregnancy. As far as the suture type goes, the mean gestational age at time of delivery between the two groups was statistically significant, with Mercelin tape being longer than green braided. The limitations of this study, it's retrospective. One important aspect of that is that the suture type used was not randomized, rather based on provider preference. We have 4 maternal fetal medicine specialists at our institution. 2 of them prefer Mercelin tape and 2 prefer green braided, so that did make it a little bit easier. Obviously, we're a single academic center, and the small sample size may limit generalizability. So in conclusion, why does this matter? The linear regression model of post-cerclage cervical length measurements could be helpful in management and counseling patients as far as when to bring a patient in for observation or administration of steroids or magnesium. And results of this study suggest that Mercelin tape may be superior to green braided suture. Questions?
Thank you. When you did your linear regression, what confounders did you control for?
That's a good question. Our statistician did that part of the analysis for us, and I told him that I wanted to make sure that regardless of the suture type, that still held true. So I know he controlled for suture type at least.
But then when you did your linear regression for suture type, what did you control for?
There wasn't a linear regression for suture type.
So that was only the absolute means that were compared?
Correct. Okay. It was a t-test.
Okay. And that was tested for normality to make sure you could use a t-test?
Yes.
Okay. So one thing I would watch out for is it's very hard to make that conclusion without confounders because many things affect preterm birth. You had 2 different types of cerclages being placed for indication. And so without controlling for that maternal age, race, parity, prior history of preterm birth, it's going to be very hard because your absolute raw data is always going to show that. So before you can make the conclusion on your linear regression about the beta coefficient and the increase, you need to add confounders in the model.
Thank you.
Dr. Spann, you have another question?
Were you able to convince the doctors who used the braided suture to convert to the...
Ask that guy over there. Thank you.
Thank you. So scan the code here. I think this should be for Dr. Fincher's presentation, and then I'll advance to see if we're doing Dr. Zhu's next, or? Okay. Our next presenter will be Dr. Anastasia Novitsky from MCG. She will be presenting on genome sequencing of patients and their families to capture genomic landscape in MRKH. Dr. Novitsky.
Good morning, everyone. Thank you for the opportunity to be here. Special thank you to GOGS and my MCG leadership, Dr. Allen and Dr. Higgins, for opportunity to present my research. My name is Anastasia Novitsky. I'm PGY3 at Medical College of Georgia, and I will be presenting my research with Dr. Lawrence Lehman on genome sequencing of patients and their families to capture genomic landscape in MRKH. We have no disclosures. Human sex development begins similarly in male and female embryos. In males, we have SRY gene on Y chromosome that initiates a cascade of events resulting in formation of testes. In testes, Sertoli cells produce anti-Mullerian hormone, which removes Mullerian system and facilitates differentiation of Wolffian duct into male reproductive tract, and that happens under influence of testosterone. In females, a lack of anti-Mullerian hormone surge leads to the opposite. It removes Wolffian duct system and promotes differentiation of Mullerian tissues into female reproductive organs, and that happens under influence of estrogen. So that's how we get upper vagina, cervix, uterus, and fallopian tubes. Mayer-Rokitansky-Kuster-Hauser syndrome, or MRKH, is the most severe Mullerian anomaly. It affects approximately 1 in 5,000 females. It's the second most common cause of primary amenorrhea. MRKH can be classified as type 1, which is isolated Mullerian defect, and type 2, which is Mullerian defect associated with abnormality in cardiac, renal, auditory, and skeletal systems. On the illustration on the bottom, you can see on the left, on your left, what normal pelvic anatomy looks like, and on the right, the structures that are missing in MRKH, or they can also be underdeveloped. So those are uterus, cervix, upper vagina, and fallopian tubes. Importantly, these patients have ovaries and they produce estrogen, so phenotypically they will be females, and it's important to distinguish these patients from patients with other conditions such as androgen insensitivity syndrome. Etiology of MRKH has been unclear for many years now. However, familial clustering points towards genetic causes. There have been 3 genes identified and supported by genetic studies to play a role in MRKH, and those are HNF1B, WNT4, and ZNH-IT3. The hypothesis for the study was that certain coding and or non-coding genes that are essential in Mullerian and Wolffian duct differentiation could be mutated in patients with MRKH. Our specific study hypothesis was to use genome sequencing of well-characterized patients with MRKH and their direct family members to detect clinically relevant candidate pathogenic variants that could be participating in MRKH development. And as we're looking at family members, we can also assess their inheritance. You would ask why we care about this. There are many reasons and that we can use this identified pathogenic variants in MRKH in clinic. It could improve our diagnosis. It would be nice to have a genetic panel that we can run on these patients, as we do a lot of it in REI and MFM. It could also be useful in our reproductive counseling, such as pre-implantation genetics or familial risk assessment. We can also understand the mechanisms of the disease and potentially come up with targeted therapies. We can provide tailored medical care to patients, especially patients with type 2 MRKH. As I told you, those Mullerian defects are associated with comorbidities in other systems. And lastly, understanding this most complicated severe Mullerian anomaly could also be helpful in elucidating mechanisms of development of less severe and more common abnormalities of the Mullerian tract, such as vaginal septum, septate uterus, or bicornuate uterus. For this study, we had genome sequencing performed on 124 individuals, 31 unrelated patients with MRKH. 7 of them were type 1, 20 were type 2, and 4 unspecified, and their direct family members. The depth of sequencing was adequate, 36.7x. Next, variants were filtered by characteristics that would make them likely to be true, rare, and pathogenic. So we used mapping quality, allelic frequency, tap consequence, and the CUT score. Next step, we used VARSAM, which is the big database, contains information from over 145 databases to categorize pathogenic potential of this variants. And lastly, we used OMIM, which is the catalog of genes and phenotypes associated with those genes to filter this variance by potential involvement in Mullerian, skeletal, renal, cardiac, and auditory systems. And as we perform genome sequencing, we also need to confirm that those variants are actually true. So a lot of times, Sanger sequencing needs to be performed, and I'm still working on that part, as it takes a lot of time. And lastly, phenotypic data was collected for patients and their family members. So we basically did a review of system for all of the participants. These are the results. So we identified more than 65,000 variants. Then we performed our filtering, used VARSAM and OMIM, as I just described, and we ended up having 15 de novo variants and 20 inherited variants, some of them coding, some of them non-coding. Most of them were variants of unknown significance, but some of them were pathogenic and likely pathogenic. I'm not going to present you several tables of these genes and why we think they're important to investigate. But I do want to highlight that when we focused on 75 genes with known association to MRKH, and this is per literature, the genes that have been reported to potentially play a role, we identified only 2 probands, meaning patients with MRKH, with likely deleterious variants. Those were non-coding HOXA11 splice donor and coding ITIH5 stop-gained variant. You can see on the bottom the pedigrees for those families. On your left is the patient with HOXA11 variant. Patient had MRKH type 1 inherited from the healthy mother. And on the right, patient with MRKH type 2 had ITIH5 variant inherited from a healthy father. These variants were inherited from one parent, so if they're actually pathogenic and play a role in MRKH development, that suggests autosomal dominant inheritance with possibly variable expressivity, reduced penetrance, and or sex-limited phenotype to females. As a conclusion, our comprehensive analysis by genome sequencing of 31 patients and their families with MRKH that runs in the family reveals that most patients with MRKH had no clear pathogenic variants in the genes with known association to MRKH. So we only found 2 patients, 29 patients had no genetic abnormalities that we have known about per literature. Several non-coding variants were identified in long non-coding RNA and microRNA, and those are regulatory players, which had high preferential expression in Mullerian structures, and they had no known function reported. I would like to emphasize that for a long time, we have been studying MRKH, and we have focused on the 1% of genome that codes for proteins, trying to explain the disorder. And it has worked for a lot of disorders. However, it doesn't seem to explain MRKH. So I do want to emphasize that it might be important to look at a broader picture and the rest of the genome, the 99% of the genome, and errors that could be happening happening at the level of the gene expression, for example, epigenetic players, methylation, acetylation, promoters, enhancers, transcription factors, as well as global modifiers such as DNA folding. And with that, I will conclude. These are my references, and I welcome any questions.
Do we have any questions? Dr. Bronk?
This is a great question. So genome sequencing, as you're highlighting, is pretty expensive. It's about $1,000 per patient. That was funded by NIH grant that Dr. Lawrence Lehman received. And I also received a small grant of $5,000 from MCG for doing this work. So I appreciated that help.
All right, thank you. Next, we have Dr. Chad Richardson from Emory, who will be presenting on the association between mild gestational diabetes and adverse pregnancy outcomes in an urban safety net hospital. Dr. Richardson.
Good morning. Oh, wow. Good morning. I must say, other than this suit, I feel very official that I have a clicker here. So I'll say that my project is entitled The Association Between Gestational Glucose Dysregulation and Neonatal Outcomes at an Urban Safety Net Hospital. My mentors are Dr. Suture Chandrasekaran, Dr. Irish Krishna, and Dr. Daniela Spielman. I'd also like to give a special acknowledgement to Dr. Sherry Boulay and Dr. Sally Owens for their contributions to our MOGO and GOGO data sets, which we'll discuss further in the presentation. I have no financial disclosures. We'll start with a background. Pregnancies complicated by gestational diabetes are at increased risk for maternal complications such as hypertensive disorders of pregnancy, birth trauma, C-section. They're also at increased risk for neonatal complications such as large for gestational age, preterm birth, and neonatal hypoglycemia. In 2009, Landon et al. Defined mild gestational diabetes, now known as glucose dysregulation, as an abnormal result on a 1-hour glucose tolerance test with an elevated fasting level on 3-hour confirmatory testing. They randomized women to treatment and then non-treatment groups and saw significant differences or significant reduction in their primary outcomes highlighted here. Now in 2024, we still have no additional guidance on how to treat this at-risk population. Prior to this, the hyperglycemia and adverse pregnancy outcome study looked at women and their one-step 75-gram glucose tolerance test in addition to the adverse pregnancy outcomes. They saw a positive correlation with maternal glucose levels and adverse pregnancy outcomes, and so the 75-gram oral glucose tolerance test was adopted as standard practice. However, in 2013, the NIH cited increasing medical costs along with a lack of neonatal outcome data to say that this was standard for care. So this brings into question, if we're going to prefer the two-step method, then what are we missing out on an opportunity to treat an at-risk population? And then also, are we missing out on the opportunity to prevent adverse pregnancy outcomes? Therefore, we conducted a retrospective cohort study using the Grady Obstetric and Gynecology Outcomes, and then also the Midtown Obstetric Gynecology Outcomes database, both GOGO and MOGO. GOGO houses delivery data from Grady Memorial Hospital, a tertiary referral center with over 50% of the births in the state of Georgia. It also serves as a safety net hospital for the medically underserved in Fulton and DeKalb counties. MOGO houses data from Emory Healthcare, the largest healthcare system in the state of Georgia. We included individuals with an abnormal 1-hour glucose tolerance test and those that were 18 years of older. We excluded those with a 2-hour glucose tolerance test, those with type 2 diabetes, those who completed an early routine glucose screening, and those less than 18 years of age. We then separated our glucose dysregulation subtypes into 3 groups, GD1 being those with no abnormal values on a 3-hour glucose confirmatory test, GD2 being those with just an abnormal fasting value, GD3 being those with an elevated post-glucose load, and then GDM being those with 2 abnormal values on confirmatory testing, therefore meeting criteria for gestational diabetes. We had results with over 1,500 women. About 31% fell into the GD1 category, 2% into GD2, 9% into GD3, and 56% had gestational diabetes. In terms of demographics, there were 32% white, 42% identifying as Black, and 36% into other categories. In our mean BMI and age, we're actually highest among the GD2 subtype. That was the elevated fasting. And then regarding delivery mode, our C-section rates were highest among those in the GD3 subtype, the elevated post-glucose load, which is actually followed by the abnormal 3-hour in GD1 at 39% and 47% respectively. Maternal outcomes were examined for this study. However, for this presentation, we'll focus in on neonatal outcomes. Our maternal data will be forthcoming as it's being submitted for presentation at a national conference. With respect to our neonatal outcomes, we saw significant differences in neonatal hypoglycemia and jaundice. Mainly in neonatal hypoglycemia, you can see that it's elevated in our GD3, elevated post-glucose load group at 16%. When it comes to neonatal jaundice, it was elevated in our GD2 subtype. That was the elevated fasting only at about 20%. Pay attention to the mean birth weights in the sense that we did have near significance at a p-value of 0.07. However, they're all at least there or slightly elevated than our GDM, so those that have gestational diabetes, so we can see the increased risk for the neonate. So in conclusion, our data demonstrates a racially diverse population with an elevated baseline risk. This opposed to prior research where the populations were largely homogeneous and had a fairly healthy relative baseline. We also see those differences that were initially disagreed upon by the NIH, where they cited the lack of neonatal outcomes. So we can see that at least there is some neonatal risk associated with maternal glucose dysregulation. Therefore, further research is needed to understand that neonatal risk and risk stratification and determine the need for neonatal surveillance in the future. These are my references, and we'll take time for questions.
Questions for Dr. Richardson? Dr. Spann.
So I'm a naysayer. How do you convince me that this is not a case control study versus a retrospective cohort?
Thank you for your question, Dr. Spann. So in mentioning a case control, you then identify the case and then look back and see your control studies. In this study, we looked retrospectively and looked at those individuals who did have just an abnormal 1-hour testing and then saw the results and looked at the maternal outcomes and then also our neonatal outcomes as well. So therefore, in not looking at the same sort of methodology that would be in a case control study.
Any more questions? Yes.
So we use the Kustan data, which is standard for ACOG. So for a 1-hour test, the cutoff was 135. And then for the 2-hour testing, we used the standard data from ACOG as well.
All right, thank you, Dr. Richardson. And last but not least, we have Dr. Briar Thompson from Atrium, who's going to present on association of microalbuminuria and adverse pregnancy outcomes in women with pregestational diabetes. Dr. Thompson.
Hi, I'm Briar Thompson. I'm now a PGY4 resident at Atrium Health Navicent. I have no disclosures. So pregestational diabetes affects about 1 to 2% of all pregnancies, and pregestational diabetes alone is a known risk factor for adverse pregnancy outcomes. Outside of pregnancy, patients with type 1 diabetes and type 2 diabetes are actually recommended by the American Diabetic Association to be screened yearly for albuminuria, using an albumin to creatinine ratio, with microalbuminuria defined as a urine albumin to creatinine ratio between 30 to 300. So microalbuminuria is actually an indicator, early indicator of kidney disease and progression to diabetic nephropathy. So given that we know that chronic kidney disease is an early indicator that is also a risk factor for adverse pregnancy outcomes, I wanted to see if this early indicator of kidney disease also is a risk factor for adverse pregnancy outcomes. So this was a retrospective observational study. Our exposure was microalbuminuria, previously defined, and we looked at patients that had pre-gestational diabetes, type 1 or type 2, and that had microalbuminuria and compared them to those patients without microalbuminuria. The patients were included in the study were at an academic variety of different settings in a large hospital network, including academic centers, community centers, and private practices. The exclusion criteria for this patient and for the study were patients that had chronic kidney disease defined by chronic kidney disease guidelines, stages 3 through 5 based on GFR, as well as macroalbuminuria. So I'm going to talk about just my primary outcomes that I looked at for the study. We looked at both maternal and fetal primary outcomes. They were composite outcomes. So for primary maternal outcomes, we included development of pregnancy-induced hypertensive disorders, acute fatty liver of pregnancy, intrahepatic cholestasis of pregnancy, peripartum postpartum cardiomyopathy, and IUFD. And then for our primary fetal outcomes, it was also a composite that included NICU admission, APGAR score less than 7 at 5 minutes, the diagnosis of respiratory distress, or patients or infants needing respiratory support for greater than 1 hour after birth. So here's the demographic factors for our study. Overall, the demographic factors are pretty similar between the patients with microalbuminuria compared to those without, but I did want to highlight the gestational age of delivery for the two. For the patients without microalbuminuria, their gestational age of delivery was on average between 36 and 37 weeks, whereas the patients that had microalbuminuria were on average delivered around 35 weeks. The patients with microalbuminuria absent, their babies on average spent about 4 to 5 days in the NICU, whereas the patients with microalbuminuria, their babies spent on average 15 to 16 days in the NICU, and that could be attributed to the gestational age at which they were delivered. And then for my primary outcomes, so we did find a statistically significant primary outcome for the maternal primary outcome. So women with pregestational diabetes with microalbuminuria were 2.8 times more likely to have this composite primary outcome of pregnancy-induced hypertensive disorders, cholestasis of pregnancy, and IUFD. This was even after adjusting for chronic hypertension, A1C at the first prenatal care visit, and maternal pre-pregnancy BMI. We did not find any statistically significant differences in the fetal primary outcome or any of our secondary outcomes that we looked at. So in conclusion, women with pregestational diabetes and microalbuminuria were 2.8 times more likely to have a composite of adverse pregnancy outcomes. Further studies, larger studies need to be done to confirm this finding, but this is something that we could be screening for in patients early in pregnancy or prior to pregnancy, preconception counseling for these patients. And I would like to thank Dr. Cynthia Rowland and the statistician Joseph Rigdon that helped me with this project.
Any questions for Dr. Thompson? Yes, Dr. Chandra-Sakari.
Thank you. So I know you looked in your pregestational diabetics, right? And a lot of those risks that you mentioned are already known risks. So how would this data change my clinical practice?
So I think that one of the things that I noticed for these patients, I looked at 5 years, and there were many patients that could have met criteria for this, but that were never screened with a urine albumin to creatinine ratio. I think that's a very underutilized test among primary care providers and nephrologists, endocrinologists for these patients, even though it's recommended. So I think that that's something that we could start doing more frequently for those patients, is looking for that specific test to see if they do meet these criteria.
Can you tell me again how you collected the urine? Was it clean catch or cath? I missed that.
It was a clean catch. These were urine albumin to creatinine ratios performed spot checks for patients.
Do you think it would make a difference if it was cath?
It shouldn't. So it's a very selective proteinuria, so it shouldn't be affected as much by not a clean catch, I would imagine.
Thank you. Great presentation, actually. 2 questions. One about baby aspirin. Majority of the patients on baby aspirin?
We actually did not look at that. That would be a good thing that we should have looked at.
And the other question about any differences in hemoglobin A1C?
Actually, the average A1C between the two populations were pretty similar to begin with, yeah.
Thank you.
Thank you, Dr. Thompson.